This morning, we're glad to have with us June Oliver. She is the clinical nurse specialist for pain management. In your opinion, what's the best approach stepwise to control pain management?
So postoperative pain comes into the acute category, and the Society for Critical Care Medicine says IV opioids are still the first line approach for acute pain. And that's true. And so knowing the various ways that we can administer it, appropriate doses, is important. There's certain characteristics about individual opioids that are important for nurses to know, such as morphine having active metabolites that will accumulate when somebody is renally impaired. So that would not be a good choice in a renally impaired patient. And certainly opioids, but multimodal analgesia is really the key that has been promoted for some time. So post-op pain that's acute requires opioids, but other adjuvants can be helpful as well. So nonsteroidals, if the patient can tolerate it, acetaminophen, those are opioid-sparing partners, really, in that process of controlling pain. So when we add the adjuvants, we don't need as many opioids. We can lower the dose. Other adjuvants, such as gabapentin, which is often used for neuropathic pain, but there is some benefit in acute pain that it can be added, as well as things that are including regional blocks, epidural infusions. So all of those things as options give us some choices that expand beyond opioids, even though opioids certainly are our first line for acute pain.
You mentioned, I know, in your session about opioid naive and tolerant patients. Explain a little bit more about that and why that makes it challenging.
So the opioid naive patient, particularly if they're post-op, is going to be a little easier. They're going to fall into our typical dosing schemes and respond more typically. The opioid tolerant patient with usually chronic pain is somebody who comes in already on regular opioids, and so they have developed a certain amount of tolerance. People who are abusing opioids also will have tolerance. The body doesn't really know whether it's prescribed or illicit. It will have the same effect. So they will not respond to the same typical dosing that an opiate naive patient will. So those challenges require some extra knowledge and some extra options. Certainly all of our adjuvants, come into play even more acutely there. We also will really want to consider the epidurals, the regional blocks. There are some other newer techniques such as ketamine infusions, sub-anesthetic ketamine infusions that can help control pain with people that have significant opioid tolerance, and then using perhaps a little bit more moderate opioid dosing. If we don't have ketamine on board and we have a lot of tolerance, we're going to have to go up on the opioids. There's really just no other alternative and titrate to effect for that acute period of pain.
Do you have any problems with nurses and their personal feelings about dealing with a patient like that?
Certainly. Substance use disorder, which is the new scientific term, professional term for addiction, calls up a lot of feelings and emotions and attitudes in individuals. And I think it's really important for all healthcare providers to be conversant with what our literature is saying. First of all, it's saying that SUD, or addiction, is a chronic, relapsing, treatable brain disease. It is not a moral failing. There is often concurrent psychiatric problems and behavior issues that makes it very challenging. But psychiatric conditions are not a moral failing either. And so we have to kind of look within ourselves as people and say, what is my scientific basis? If I consider myself a well-grounded scientific practitioner, and be honest about what are my attitudes that I'm grappling with. And I think if we're honest about that, that gives us an opportunity to say, yeah, I have some attitudes that don't line up with what the scientific basis is here, and find some ways to address those with our colleagues, honestly,
Right.
rather than just venting about the patient, that's asking for too much pain medicine. Maybe say, I'm having some attitude, concerns with this patient, and find someone, maybe a pain specialist or an addiction specialist, a psychiatrist, to say, is there some way, or a psychologist, that we can have a conference, even a team conference about this patient, and bring in the different specialties.
Discussion going on the All Nurses website. Someone wrote about, labeling it as a disease, and a lot of nurses came and said, well, then you're giving them an excuse or a reason to do what they're doing. And so it is a problem.
And one thing also that I do recommend often to people is, I think it would benefit every healthcare practitioner, nursing, physician, therapist, whatever, to go a few times to an open meeting, a 12-step meeting, whether it's Alcoholics Anonymous, Narcotics Anonymous, and hear some of the stories of people that have recovered. Because in the hospital, we see the subset of people often who are not recovering, who are relapsing, who have uncontrolled psychiatric problems. But people do recover. It is possible. There are treatments that are helpful. There are social and spiritual connections and supports that can help these people. And I think it's important to be exposed to that, to counterbalance the subset of people that we're dealing with, and we feel like, well, nobody ever recovers. But they do.
What kind of ethical consideration should nurses and providers take?
Well, that's a big topic.
Yes.
Much has been written, much has been said. So to try to give some take-home points for that, I think we need to keep a balanced view. As human beings, we tend to swing with this pendulum over to one side and then over to another side. I've been in nursing for a while, so I remember when you were supposed to put up with severe pain as long as you could, and then we would bring in the IM, Demerol, and Visceral, until maybe 4 hours later it would repeat the same thing. So, we came from a place where pain wasn't recognized as a significant problem, and we didn't really assess it. And we treated rather aggressively. So the opioid epidemic, certainly has increased. That is not, in doubt. Prescription medications have contributed to that, but some of the information out there is not completely accurate in my view, and somewhat misleading. So I would encourage people to ask questions about the statistics and the source of those statistics. So prescription opioids is leveling off, actually, and declining recently in some studies, but IV heroin and illicit fentanyl are skyrocketing. So we do have an illicit opioid crisis as well as frequent prescription use. They are different animals. They're both opioids, and again, the body doesn't really know, was prescribed or illicit, but they really are different societal kind of problems. So the ethics would be, be informed in terms of what's happening. Remember that pain is really a human right in our society for a proper assessment and treatment. We don't want to have people suffer needlessly. But we have to be informed about what are the risk factors. So I think every nurse, every prescriber, every physician needs to understand more about substance use disorder and addiction than perhaps we used to. What are the risk factors? What's documented in the literature? How do you monitor for them? How do you implement multimodal therapy where you're not just depending on opioids? How do you integrate psychology? How do we look at function, not just pain scores? So a more holistic approach. And then how do we monitor for misuse of what we are prescribing? And how do we offer people treatment? Do we just discharge them from our service if we find out that they're misusing? Or do we have a referral plan? Here are the places you can go. I think you need further assessment and treatment for this. And so I think every prescriber needs to have some skills in assessment and intervention for substance use disorders.
Thank you so much.
Well, my pleasure, and nurses make a huge difference to the patient at the bedside in pain management and so many other ways. So I would say what you know and what you do makes a big difference for the patient.